Welcome back to the Deep Dive. And today, we're shifting gears completely.
We really are.
Yeah, we're not just browsing through interesting articles or, taking a casual look at a topic. Today, we are putting ourselves and you in a very specific, very high-pressure scenario.
I can feel it already.
I want you to imagine it's 2 in the morning. You're surrounded by stacks of textbooks. You've got Miller, you've got Morgan, all of them.
And that lukewarm coffee is sitting right next to you.
Exactly, the lukewarm coffee. And the Gujarat University MD Anesthesiology final exam is just looming over you like a thundercloud.
That's a vivid image, and honestly, it brings back some mild PTSD. But you're right, we are not just chatting today. I am stepping out of the friendly expert role and putting on my senior faculty hat.
Oh boy.
I'm the external examiner sitting across the table from you at the Viva station. I am the one marking your 20-mark theory paper with a very red pen.
Okay, I feel the pressure.
We aren't here to just know the topic. We're here to master the exam technique required to pass, and hopefully to pass with distinction.
I can feel the stress levels rising already. So what is the mission for today? What is the absolute beast of a topic that we need to tame to make sure we get through this?
We're tackling the massive transfusion protocol. MTP, we're going to cover everything: indications, components, pathophysiology, and of course, the complications.
And why this one specifically?
Because it's a guaranteed exam favorite. I mean, it is everywhere. You might get it as a full 20-mark long answer question in paper 2.
Right.
You might get it as a short note on, say, complications of massive transfusion, or, and this is where students often crumble, you walk into a Vita station, the examiner looks at you over their glasses and says, "Doctor, there is a patient bleeding out on the table. BP is 70 systolic. Go."
That is the nightmare scenario.
Yeah.
You just freeze, you stutter, and it's game over.
It can be.
So the goal here is to give our listener the exact structure, the key words, the clinical logic to just crush that question.
Exactly. We want to roadmap this precisely how a student should write it in their answer booklet. We need to move beyond the basic idea of giving blood. Any first-year resident knows that.
Right.
To pass your MD, you need to talk about structure, protocols, recent trials like PROPPR, and the deep physiology behind all the chaos. We're going to break this down into 14 specific sections, just like an ideal long answer.
Okay, let's do it. Let's unpack this. Section 1, Introduction and Exam Framing. If I'm writing that long answer or starting that Viva answer, where do I begin? I feel like starting with, "It's when you give a lot of blood," is probably a failing opening.
That's a fast track to a mediocre score at best.
Yeah.
You begin with precision. In an MD exam, a woolly definition, as you put it, loses marks immediately. You have to frame the concept of massive hemorrhage correctly.
Okay, so what does that mean?
It isn't just about volume loss. It's about the rate of loss exceeding the body's compensatory mechanisms. It is a physiological race against the clock.
So it's a race against time.
It is a race against the bloody vicious cycle. That is a key phrase. You need to use that phrase.
The bloody vicious cycle.
Yes. If you delay recognizing the need for MTP, you allow the patient to enter this cycle where bleeding causes shock.
Right.
Shock causes acidosis and hypothermia.
Which then makes the bleeding worse.
Exactly. Acidosis causes coagulopathy, which causes more bleeding. The introduction of your answer must highlight that MTP is a protocol-driven attempt to break this cycle before it becomes irreversible.
Got it. So we understand the urgency. Okay, let's get concrete. Section 2. Definitions of massive transfusion. I know there are a few floating around in the textbooks. Which ones are the high-yield ones for the exam?
There is a holy trinity of definitions. They're in all the standard texts, Miller, Morgan, and you must memorize them. If you write these 3 down, you are safe.
Okay, what's number 1?
Number 1 is the traditional sort of retrospective definition, replacement of one entire blood volume within 24 hours.
Okay, and for a typical adult, what does that look like in numbers?
We're talking approximately 70 illiters per kg, or essentially greater than 10 units of packed red blood cells, PRBCs, in a 24-hour period.
10 units in 24 hours. That's the classic one.
Yeah.
But let's be real for a second. If I wait 24 hours to look back and say, "Oh, wow, that was a massive transfusion,"
yeah,
the patient is probably...
The patient's probably already dead or in the ICU. You were absolutely right.
It feels clinically useless in the heat of the moment.
And pointing that out shows the examiner you have clinical sense. You say, this is the retrospective definition. That is why we have the dynamic definitions. This brings us to number 2.
Which is?
Transfusion of greater than 4 units of PRBCs in 1 hour with an anticipated ongoing need. That is the one that should be setting off alarm bells in the operating room.
That makes so much more sense. If you're hanging the fourth bag in an hour and the suction canister is still filling up with red, you are in serious trouble.
You're in ATP territory. And what's the third one?
You tell me.
The third is loss of 50% of total blood volume within 3 hours. So you have the 24-hour definition, the 1-hour acute trigger, and the 3-hour volume loss definition. You need all three to show the examiner you've read the literature thoroughly.
Right. And what about for kids? For pediatric patients, I assume 10 units doesn't apply to a toddler. If you give 10 units to a kid,
you have done something very wrong. Correct. For pediatrics, Miller gives us a specific definition. Transfusion of greater than 50% of total blood volume, or TBV, in 3 hours.
Okay.
Or, and this is the terrifying one, support for blood loss greater than 10% of total blood volume per minute.
10%.
Yeah.
That means they could theoretically bleed out their entire volume in 10 minutes.
Yes, that is a torrential, catastrophic bleed. It highlights that in PEDS, you have absolutely zero margin for error.
That's just massive. Okay, so we have our definitions. We know what it is.
Yeah.
Now, Section 3, indications for activating MTP. When do we actually push that button?
This is an exam favorite because it tests your ability to categorize your thoughts under pressure. Don't just list random surgeries. Group them logically. First and most common, trauma.
Right.
Specifically, trauma with uncontrolled hemorrhage where damage control resuscitation is required.
Damage control. We'll get to that concept in a minute, I'm sure. What's the second group?
Obstetric hemorrhage, postpartum hemorrhage, PPH, placental abruption, uterine rupture, all the big ones.
Okay, is there a difference in how those patients bleed compared to a trauma patient? Or is blood just blood?
There is a massive difference, and this is a nuance that impresses examiners. In obstetric hemorrhage, the coagulopathy can be faster and much more severe.
Why is that?
The uterus and the placenta are incredibly rich in something called tissue factor. When they're damaged, they release this into the circulation, which can trigger disseminated intravascular coagulation, or DIC, very, very quickly. So the urgency for things like fibrinogen is even higher in OB than in trauma.
Wow, okay, got it. So trauma, OB. What else?
Major surgical bleeding, think liver transplantation, especially during the anhepatic phase or on reperfusion, cardiac surgery, of course, or major vascular injuries like a ruptured aortic aneurysm.
And the last category.
And finally, gastrointestinal bleeding. We're talking about massive variceal bleeds where hemodynamic stability is completely lost.
Now, you mentioned earlier that waiting for 10 units is too late. Are there predictors we can use? Something, to impress the examiner with?
Absolutely. If you want those extra marks, you must mention the ABC score.
ABC score.
The assessment of blood consumption. It's in Miller. It's a very simple scoring system with 4 components.
What are they?
It's 4 simple questions. 1, is there a penetrating mechanism? A stab wound, a gunshot.
Okay.
2, is the systolic blood pressure less than 90 millirem Hg?
Yep.
3, is the heart rate greater than 120 BPM?
Tachycardic.
And 4, is there a positive FAST scan? That's the focused assessment with sonography in trauma.
So it's basically asking. Penetrating injury, hypotensive, tachycardic, and blood in the belly.
Precisely. You get 1 point for each yes. A score of 2 or more predicts the need for massive transfusion. It is simple, it is clinical, and it shows you know how to assess risk before the patient crashes.
I like that. It's a proactive tool. Okay, let's move to the science bit. Section 4. Pathophysiology of massive hemorrhage. I feel like shock is too simple a word here. We need to go deeper for the MD exam.
We do. Of course, we start with hemorrhagic shock, the neuroendocrine response, the vasoconstriction to save the brain and heart, eventually leading to tissue hypoxia and lactate. But the real key concept here, the one you must explain clearly, is trauma-induced coagulopathy, or TIC.
And that is different from DIC.
Yes. Do not make the common student mistake of just calling everything DIC. TIC is a distinct early event. It is driven by the tissue injury and the shock hypoperfusion itself. This activates the protein C pathway.
Protein C, wait, that's an anticoagulant. Right.
Exactly. It's a complete paradox. You are bleeding, so you need to clot. But because of the shock state, the body activates protein C, which then goes on to inhibit factor V and factor VIII.
So the body effectively anticoagulates itself.
Yes. Before you even start diluting it with fluids, it is a maladaptive response to severe trauma.
That is wildly counterintuitive. You're bleeding, so your body makes it harder to clot.
Exactly. And then on top of that, you have the lethal triad. If you are going to draw a diagram in your exam, and you absolutely should be, this is the one.
Okay, walk us through the corners of the lethal triad.
Point 1. Hypothermia. This is pure physics and biochemistry. Coagulation is just a series of enzymatic reactions.
And enzymes work at 37 degrees.
Correct. As the body temperature drops below 34 degrees Celsius, the enzyme kinetics just plummet. The clotting cascade effectively stops working. It doesn't matter how much plasma you give. If the patient is cold, the enzymes won't fire.
So warm the patient. Point 2.
Acidosis. Metabolic acidosis, specifically from lactate due to poor perfusion. Acidnappus alters the three-dimensional shape of the coagulation proteins.
Right, from biochemistry. Protein function depends on shape.
And if the pH drops, the shape changes, and the factors can't bind to the platelet surface efficiently. It's like having the wrong key for a lock.
And point 3 is the coagulopathy itself.
Coagulopathy. This is the end result of consumption, using up all your factors and dilution if we pump them full of saline. And these three, hyperthermia, acidosis, coagulopathy, they feed into each other. That's the bloody, vicious cycle. MTP is designed specifically to break this cycle.
Okay, so we know the enemy. Now let's talk about the weapon, Section 5. Components of the massive transfusion protocol. The alarm goes off. The porter runs to the blood bank. What comes back in the pack?
The pack is designed to mimic whole blood. We usually don't have fresh whole blood available anymore, so we have to reconstruct it.
Okay, what's in it?
Component 1, packed red blood cells, PRBCs. These are for oxygen delivery, for DO2. In a massive bleed, we are not looking for a normal hemoglobin of 12 or 14. We want to keep them alive. The target is usually around 7 to 9 grams per deciliter.
Component 2.
Fresh frozen plasma, FFP. This is your source of all clotting factors. But remember the logistical bottleneck here. Thawing time.
Oh.
You have to call early because FFP takes 20 to 30 minutes to thaw unless your center has pre-thawed plasma, which some do.
Right. Component 3.
Platelets. Essential for the primary plug. In MTP, we usually get a pool of platelets, which is derived from multiple donors.
And component 4. I feel like I said the one people sometimes forget.
Cryoprecipitate. And if you forget this in the exam, you are in big trouble. Cryoprecipitate is the single best source of fibrinogen. It also has factor VIII and von Willebrand factor, but for MTP, we care about the fibrinogen.
Why is fibrinogen so important here? Why not just rely on the FFP to provide it?
Because in massive bleeding, especially as we said, obstetric bleeding, fibrinogen is often the first factor to reach critically low levels. FFP contains fibrinogen, sure, but in a much lower concentration. To replace a significant deficit using only FFP, you would have to give so much volume that you'd cause taco and overload the patient.
So cryo is like a concentrated fibrinogen bomb.
That's a great way to put it. It's a small volume with a big fibrinogen punch.
Okay, so we have the ingredients. Now how do we mix them? Section 6. Transfusion strategy. This seems to be where the biggest debate has been. The ratios.
This is the exam favorite part of the discussion. You absolutely have to discuss fixed ratio versus goal-directed therapy. The current standard for the initial blind phase of resuscitation is the fixed ratio.
Which is usually
1.1.1. That is 1 unit of PRBCs to 1 unit of FFP to 1 unit of platelets, or more accurately, 1 pool of platelets.
And where does that 1.1.1 ratio come from?
It comes from military data initially, from conflicts in Iraq and Afghanistan. But for your exam, you must mention the PROPPR trial.
PROPPR.
Yes. It compared a 1.1.1 ratio against a 1.1.2 ratio, so giving less plasma. The result was that the 1.1.1 group achieved hemostasis faster and had a lower rate of death by exsanguination in the first 24 hours.
So they stopped bleeding faster.
Exactly. It didn't change the overall 30-day mortality statistically, but saving patients from bleeding out early is the entire goal of MTP.
So 1.1.1 is designed to mimic whole blood.
Precisely. The whole idea is to avoid what we call dilutional coagulopathy. For years, we used to resuscitate with liters and liters of crystalloids, just salt water. All you're doing is diluting the remaining factors and causing a hyperchloremic acidosis, making the whole problem worse. So limit crystalloids. If they're bleeding blood, give them blood products.
But 1.1.1 is just the start, right? You mentioned goal-directed.
Yes. The 1.1.1 ratio is what you do when you're flying blind before you have lab results. Once you have stabilized the patient or ideally have labs available, you switch to goal-directed therapy.
And that's based on?
That's where you use viscoelastic testing like TEG or ROTEM to treat specific deficits, but we'll get to that in the monitoring section.
Okay. Before we get to monitoring, let's talk about the things we do alongside the blood. Section 7, adjunctive measures. The other critical stuff.
These are the things that save lives while the blood is running. Number 1, and we've already touched on this, temperature management.
Warm the patient. Warm the fluids.
That's the mantra. You need high-flow fluid warmers, you need forced air blankets like a bear hugger, you need to cover the patient. Remember, hypothermia is lethal.
Number 2.
Calcium replacement. This is a critical Viva trap. The anticoagulant in blood bags is citrate. Citrate works by chelating by binding to calcium.
Okay.
When you pour in unit after unit of blood, you're pouring in a massive citrate load. It binds the patient's own ionized calcium.
And what happens when ionized calcium gets too low?
Hypocalcemia causes severe hypotension and heart failure. It reduces myocardial contractility. It's an absolute disaster. The rule of thumb you should quote is, give calcium chloride or calcium gluconate for every 3 to 4 units of blood products. Don't wait for the lab result. If you're on unit 4, give calcium.
That's a great practical tip. What about their acid-base balance?
Fix the perfusion to fix the lactate. Don't just chase the numbers by giving sodium bicarbonate. That doesn't fix the underlying problem of shock. Restore volume with blood products, restore perfusion, and the body will clear the lactate.
And finally, a drug that's become standard of care. Tranexamic acid, or TXA.
Yes, an antifibrinolytic. It prevents the clot, once formed, from breaking down. The key here is timing.
Right, from the trials.
Yes. The CRASH H2 and Woman trials showed it must be given early within 3 hours of injury or onset of bleeding. If you give it too late, it might actually be harmful. So, in your exam answer, TXA is an early bolus, usually 1 gram, followed by an infusion.
Okay, section 8. Monitoring. We are pouring fluids in, we are giving calcium, we're warming them. How do we know what's actually happening inside the patient?
Hemodynamically, you need to know that blood pressure is a late marker. A young, fit patient can maintain their BP until they completely fall off a cliff.
So what's a better marker?
Look at perfusion markers, lactate and base deficit from an arterial blood gas. But for the exam, the gold standard for monitoring during MTP is viscoelastic tests, TEG or ROTEM.
I always find those TEG traces confusing. It looks like a cigar or a champagne flute. Can you simplify it for the exam? I need the high-yield version.
You need to know 3 parameters and their treatments.
Right.
It's very simple. Imagine the shape. It starts as a flat line, then opens up into the cigar shape.
Yeah.
First, the R time, or reaction time. This represents the time it takes to start forming a clot. If it's long, you are low on clotting factors.
So the treatment would be?
Give FFP. Long R time equals give fresh frozen plasma.
Okay. Long R time means give plasma. What's next?
Second, the MA, or maximum amplitude. This is the widest part of the cigar. This represents the strength of the clot, which is mostly determined by platelets and their interaction with fibrin. If the MA is low, so you have a skinny cigar, you need platelets.
Low MA means give platelets. Got it.
Third, the LY30. This measures lysis, or clot breakdown, at 30 minutes. If the tail of the cigar narrows down very quickly after reaching its maximum amplitude, it means the clot is dissolving too fast. That's hyperfibrinolysis.
And the treatment for that is TXA.
Exactly. Give tranexamic acid, so it's simple. R time equals FFP, MA equals platelets, LY30 equals TXA. That is extremely high yield.
What about the standard labs we send off?
You send them IHPASB, platelets, PTA, PTT, Fibrinogen, but you have to mention the lag time. By the time the result comes back from the central lab, the patient has changed. That is why our point-of-care TEG is preferred. But if you are using labs, watch the Fibrinogen. The critical target is to keep it greater than 150 milligdl, or as we said, greater than 200 milligdl in obstetrics.
Right. Section 9. Complications. This is often a standalone short note question. Discuss the complications of massive transfusion.
You have to group them logically. First, metabolic complications. We've already discussed hypothermia from cold blood and hypocalcemia from citrate, but don't forget hyperkalemia.
Why hypotassium?
Stored blood, especially if it's old blood nearing its expiry date, leaks potassium from the red cells as they lies in the bag. If you rapid transfuse several units of old blood, you can cause a cardiac arrest from hyperkalemia.
Okay. What else in metabolic?
Acid-base disturbances. Initially, you get acidosis from shock. But later, maybe a day later, you can actually get metabolic alkalosis.
Interesting. How does that happen? Acidosis first, alkalosis later.
Exactly. The liver metabolizes all that citrate you've infused into bicarbonate. So 24 hours later, your patient might be significantly alkalotic.
Okay, so that's metabolic. What's the next group?
Then coagulopathic complications, mainly the dilutional coagulopathy if your ratios aren't maintained, and then a very important group, respiratory complications. 2 big acronyms here that you must know, TACO and TRALI.
Differentiate them for us. This is a classic exam question.
TACO is transfusion-associated circulatory overload. Basically, you gave too much volume too quickly. The patient develops pulmonary edema. They have a high CVP. The treatment is diuretics.
And TRALI.
TRALI is transfusion-related, acute lung injury. This is an immune reaction. Antibodies in the donor plasma attack the recipient's lungs. It causes non-cardiogenic pulmonary edema. It is the leading cause of transfusion-related death.
And finally, infection. I assume we have to mention it.
Yes. Viral transmission hepatitis B, C, HAV. The risk is incredibly low now due to screening, but you must mention it for completeness.
Moving on to Section 10. Termination of MTP. When do we stop? We can't just keep giving packs forever.
You stop when the key criteria are met. Number 1, and the most important, surgical control of bleeding. The surgeon has to have stopped the source.
Makes sense.
Number 2, the patient is achieving hemodynamic stability. And number 3, you're seeing correction of the coagulopathy on your TEG or your labs.
And then what?
Once you stop, you must transition. Stop the pack delivery, move to targeted transfusion based on specific lab results, and a crucial point, communicate. Tell the blood bank to stop thawing plasma and platelets. Don't waste those precious resources.
Okay. Section 11. Special situations. We touched on these, but let's just solidify them. Trauma versus obstetric versus PEDS.
In trauma, the key concept is hemostatic resuscitation and permissive hypotension. You actively keep the systolic blood pressure around 80 to 90 millimeters of mercury until the surgeon clamps the vessel.
Why would you do that? It seems dangerous.
Because if you raise the pressure too high, you'll pop the clot that's trying to form. You'll dislodge the early fragile clot and cause more bleeding. But there's a huge exception.
Which is?
Traumatic brain injury, TBI. In a patient with TBI, you cannot allow hypotension. You need adequate cerebral perfusion pressure for the brain. So TBI mandates a higher blood pressure target.
Okay. And obstetric patients.
The main warning here, again, is that rapid fibrinogen depletion. You need to be thinking about and using cryoprecipitate or fibrinogen concentrates much, much earlier than you might in a standard trauma case.
And for pediatric patients.
Everything is weight-based, ml per kg. MTP packs are smaller or they're aliquoted from adult units. The 1.1.1 concept still applies, but the volumes are calculated with extreme care.
Right. Okay, Section 12. Common exam questions and Viva traps. You're the examiner. What are the classic mistakes where I fail?
Prep number 1, ignoring calcium. If you run through a whole scenario and you pump in 10 units of blood products, but you never once mention giving calcium, and I ask you why the patient's heart arrested, you will fail that station.
It's that critical.
It's that critical. Trap number 2, confusing FFP and cryo indications. Remember, FFP is for general volume and replacing all the factors. Cryo is specifically for fibrinogen. If the fibrinogen is low, the answer is cryo.
Okay. Trap 3.
Trap number 3, what is the universal donor?
O-negative.
Yes, but there's a nuance. In a massive shortage or a mass casualty event, we triage our resources. We reserve O-negative for women of childbearing age to prevent Rh sensitization. For males or postmenopausal women, we might actually use O-positive to save the precious O-Neg supply. That's a detail from Miller that shows you understand resource management in a crisis.
Wow, that's a very specific high-level point. What about a safe answer? If I get stuck in a Viva, what's a good sentence to fall back on?
My priority is to stop the bleeding, which is usually a surgical task, while simultaneously replacing the blood losses with a 1.1.1 balanced transfusion strategy in order to prevent and treat the lethal triad. That sentence will save you.
Section 13, diagrams and exam presentation. If I'm rating this 20-mark answer, what should I draw to get extra marks? Visuals are key. Draw a simple MTP flowchart. A box for trigger, an arrow to a box for call blood bank, arrow to pack 1, arrow to labs, arrow to pack 2. Simple.
Okay.
Draw a table comparing the classes of hemorrhage from the ATLS classification. It shows you the fundamentals.
And the TEG trace.
And absolutely draw TEG tracing, just the basic shape. Show a normal one and then maybe draw one that is flat to show coagulopathy or one that tapers off quickly to show fibrinolysis. These simple visuals break up the text and gain you extra marks every time.
Finally, Section 14, summary and exam conclusion. Give us the 30-second recap for that final paragraph of the exam answer.
To conclude, MTP is a life-saving, multidisciplinary intervention for catastrophic hemorrhage. Its success relies on early recognition, rapid activation of a predefined protocol, and adherence to the principles of damage control resuscitation. We target a 1.1.1 ratio of blood products to mimic whole blood. We aggressively treat the lethal triad of hypothermia, acidosis, and coagulopathy. And we utilize viscoelastic monitoring to guide ongoing therapy. The ultimate goal is to bridge the patient to definitive hemostasis and transition back to physiological stability.
And a final word of encouragement for the student who's been listening to all this.
You know the physiology, you know the numbers now. Stick to the protocol. Don't get flustered by the chaos of the scenario, whether it's real or in a Viva. If you prioritize the ABCs and you constantly think about preventing and treating that lethal triad, you will pass. You've got this.
Visualize that pack opening. Visualize the calcium going in. You are ready. Thanks for joining us for this high-yield revision session on the deep dive. Good luck at the exams.
Good luck. Go crush it.